Hello everyone. Today our topic of discussion will be multiple sclerosis. See, the multiple sclerosis, as you can see, is a chronic autoimmune inflammatory condition with selective destruction of myelin sheath in CNS. It has female preponderance of raised one, that is, females are getting affected more than the males, and its etiology is multifactorial. The actual cause we don't know, but what we have been proposed is that it has a good correlation with HLA-DR2, vitamin D deficiency, viral infections like Epstein-Barr, and smoking, etc. How the patient will present with. The clinical features include it has an abrupt or insidious onset, may involve pyramidal tract, optic nerve as optic neuritis, posterior cord or cerebellum or medial longitudinal fasciculus. That means the involvement is almost everywhere in CNS. And you can see the classification. You can present as a relapsing limiting multiple sclerosis with discrete attack and complete recovery. The patient can go home. Secondary progressive, well, there will be a clinical steady deterioration. Primary progressive again, the same. And tumefactive MS, where the lesions which is caused on the CNS will be more than 2 centimeter. How do you diagnose it? We can diagnose multiple sclerosis by taking an MRI scan, which is now said to be the gold standard, where we can see the lesions of more than 2 centimeter, which is perpendicular to the lateral ventricle, which are known as Dawson's fingers. You can make out the Dawson's fingers in this image, where we can see finger-like extensions, which is periventricular in location. Next, we can do an evoked potential. Evoked potential means it is used for assessing the functions of afferent, that is the sensory pathway, and the efferent, that is the motor pathway. If this evoked potential, if one or more evoked potential is abnormal, it is said to be MS, and it's mostly seen in almost 90% of cases. If you do a CSF studies, you can see 5 to 60 mononuclear cells, that is called mononuclear pleocytosis. Increased IgG in the CSF. If you do a protein electrophoresis, you can see oligoclonal IgG bands. You have to get at least 2 or more discrete oligoclonal bands. How do you treat it? See, the treatment, if the patient is having an acute attack, you can start the patient with injection methotrexate 500 to 1 gram for 3 to 5 days. And if the patient is still unresponsive, you have to go for a plasma exchange, which is done once in every 14 days. The third option is we can go for disease modifying drugs like interferon beta, glatiramal acetate, natalizumab, rituximab, fingolimod, and cladribine. And the last option you can see, we have an anti-CD20 monoclonal antibody known as ocrelizumab. Thank you.